Good afternoon, everyone. Welcome to today's Cardiac College online session. It's Paul O speaking, and it's my pleasure to welcome you to this week of online education. This title slide it demonstrates that you'll see that there'll be a somewhat different format for this week and the next few weeks. Mondays are now going to feature a Live and Thrive with Heart Disease theme. And today we'll tackle one of our heart health topics around medications. Tuesdays, we'll have two events. 10 o'clock in the morning is Women with Heart, and 1 o'clock in the afternoon will be a new series with Rob Bertelink, our featured guest speaker on many occasions and exercise aficionado. And he'll be taking you on a walk and talk on Tuesdays at 1 o'clock and again on Thursdays at 1 o'clock. Wednesdays will remain Heart Healthy Eating Day, and our dietitians will go through sessions at 1 o'clock p.m. Some of those sessions may be a recap of education that we have provided previously, but they will include a live question and answer component. So we do look forward to engaging with you regularly and continuing to provide education that we hope will be of value to you. As we said, today's session is a part 2 about heart medications. And there's a couple of topics that I did want to focus upon today. This is me before we get there. And if you have any questions, I'll be pleased to entertain them in the Q&A part of the Zoom platform at the end of the session. Reminder that these sessions are really for education only, and we would ask you to consult with your healthcare provider and or pharmacist for specific advice about your situation. Today's session will feature two updates. One is about new guidelines around the judicious use of aspirin. The second is an update about the benefits and risks of those medications that are called ACE inhibitors and angiotensin receptor blockers, ACEs and ARBs respectively, in relation to COVID-19 infection. And we'll go back to some of the information we presented a couple of months ago. Gosh, has the pandemic been going on that long? And provide some new information based upon some observational studies that have been published over the last few weeks. We'd encourage you to submit your questions because I think this is going to be the more important part of any of these kinds of encounters. And we'll also, again, direct you to speak with your physician or pharmacist if you have any specific questions about your medications. So part 1 is about aspirin. And you may recall from a few weeks ago that we had this discussion about the cells that float around in your bloodstream. And in fact, these are the cells that are manufactured in the bone marrow of your body before they enter into the blood system and float around. We'll remind you that there are different colors of cells that are really highlighted or enhanced in this pictogram. The red cells are those kind of discs that carry around oxygen, and hence they are nice and red when they attach to hemoglobin. And that's a very important function to deliver oxygen throughout our body. These fluffy sort of cells that are purple in color or a whitish purple represent the white blood cells that are involved in fighting off infection. And we'll remind you that there are these interesting little yellow colored cells in this diagram that represent the trillions and trillions of platelets that float around in your body and are responsible for the blood clotting system. At rest, this electron micrograph, a really blown up image of platelets, shows that these things can stack and unstack very innocently over time. And they really don't have a function at rest, but when they get excited, you see they actually transform in their shape. They go from a resting flat structure to something that is active and sticking fingers out as stylized here. And these platelets, then when they are activated because of chemical signals, start to stick out these fingers. in sciencey details, these things are called glycoprotein 2B3A receptors. We can think of them as hands or arms that stick out, and you can see that they can start to grab each other and form a whole clot, a clump. And in areas like this represents a coronary artery, for instance, where there's been a buildup of lipid plaque over many, many years, the thin surface on top of that is prone to be irregular or rupture at times. And the platelets, when they see that, they sense that maybe this area has been kind of damaged, and the platelets will go ahead and try to stick to that, thinking that they are trying to do you some good. Unfortunately, if a whole bunch of platelets get stuck there and then they start to block up the blood, then it ceases to flow. And that's one of the inciting events in the setup of a heart attack. And there is a close-up picture where you can see all these little small platelets that used to stack and unstack have now grabbed together and are stuck together, a platelet clump. And we'll remind you that in the setting of an angioplasty with the leaving behind of a coronary stent, that once all this hardware is removed and we can see that there's been some underlying trauma to the blood vessel from the inside, that this sets up a place where many things can start to stick together, including the platelets trying to get stuck into this environment. We reminded you that there's many chemical signals that make these platelets get excited and stick their fingers out. And the central one here, and this is the relevant setup for the next part of this discussion, is in the middle here, there's a chemical factory that sets up these little chemical signals. One of them is called thromboxane A2. You can even tell from the name thromboxane, thrombo meaning clot. And this is a chemical signal that is formed within the platelet that tells this platelet and ones around it to stick its fingers out and clot together. The interesting news is that we've known for some period of time, centuries in fact, that there's a way of blocking these platelets from sticking together by blocking one of these key steps in the middle called cyclooxygenase. And by blocking cyclooxygenase, we have less thromboxane formed, which means that there's less fingers sticking out and less clumping that'll happen together. And of course, the simple way of blocking cyclooxygenase is just by feeding this platelet an aspirin. A little baby aspirin, 81 milligrams per day, will knock out many, many of these platelets in your system and hence thin the blood out. You recognize this because if you're taking aspirin and you bump into a table and you end up with a bruise, it's probably bigger than it would have ever been before. Some of you get bruises on your arms or your legs spontaneously without any trauma. And if you nick yourself shaving, you'll find you're just going to bleed for a minute or two longer than you might have before. It will stop with some pressure and some toilet paper. But these are the effects of aspirin, thinning out the blood. And if you've had a heart attack or a stroke, or you've got blockages in the blood vessels in your body, aspirin works very well to prevent the next thing from happening. And this is why this would be a standard medication that is offered to people who might have had a heart attack or a stroke, for instance. And what this graph is showing us on the vertical axis is the risk of developing another heart attack or stroke or some other cardiovascular event over the period of the next few years. The orange bar represents the experiences of people who are taking aspirin, and the pink bar represents the experience of thousands and thousands of people who were not taking aspirin. They were taking a matching sugar pill. And you can see that the risk of serious vascular events is about 25% lower when you're taking aspirin. And individually, the risk of developing a stroke, if you had a first stroke, or a stroke if you've had a heart attack, is about 25% lower. And the risk of developing a secondary heart attack is about 25% lower if you're taking aspirin. So one single little baby aspirin is a great way of reducing one's risk of developing another vascular event. Now, excuse me, let me just take a drink of water. Many of us, if you're following news headlines or reading a bit of the medical web pages, would have seen information like this about updated guidelines or new studies about aspirin, because the information that we've just described holds really true if you've had a heart attack or stroke. But it's confusing sometimes because we've seen headlines come out that said maybe we need to rethink this. And in our Canadian Medical Association journal, in the May 2020 edition, I'm holding it up here and I'm showing you it on the screen. The leading headline was a guideline on acetylsalicylic acid. That's the long chemical name for aspirin, for cardiovascular disease prevention. And ASA is not recommended for primary prevention of a first vascular event. And I thought it'd be worth just diving into this in a little bit of detail to say, what's up with this? Do I need to change anything that I am doing? Because we just went through an interesting story that aspirin can actually have a very positive effect on preventing my platelets from clumping up together and blocking off some blood vessels. So the deal here is that the guideline that was published in the Canadian Medical Association journal, the full name was called this, the Canadian Stroke Best Practice Recommendation, 7th edition, acetylsalicylic acid for prevention of vascular events. It says a couple of things here. One is that the people, the medical experts who manage individuals who might have had a stroke, are very interested in aspirin, as are the cardiologists who are very interested in preventing heart attacks, as are the vascular surgeons who are interested in preventing blockages in the neck or in the legs. All of them use this important and powerful, very simple medication called acetylsalicylic acid or aspirin or ASA. So this is an update from the stroke group. They've done this many times before, which says that we've known about aspirin for a long period of time. And every few years, we need to come together and think about what is new in the medical field in terms of new studies. And that partner agencies like the Heart and Stroke Foundation that is shown here may help in the development of some of these guidelines and will definitely help in the propagation of this information. So simultaneous with the publication of this article in the Canadian Medical Association journal, the Heart and Stroke released on its website and also put out into the mainstream media information about aspirin for prevention and what you need to know. And in the next two slides, I'll show you the highlights. Number one is that the stuff we knew before about if you've had a heart attack, a stroke, or blockage of the blood vessels in your belly or your legs, then aspirin is still strongly indicated for secondary prevention. Secondary means you've already had one of these events or diagnoses, and we're trying to prevent the next thing from happening. And aspirin is still a key, simple tool that will help us prevent bad things from happening in the future and reduce the risk by about 25%. So that's stuff that is still true from before. The new stuff, based upon a number of large studies that have been done recently, would say that aspirin is no longer recommended for primary prevention in individuals without a history of cardiovascular disease, stroke, or peripheral artery disease. So primary prevention means that we're trying to prevent the first heart attack or the first stroke. And the second part here says that if you don't have a heart attack and you've never had a stroke and you don't have any blockages, then aspirin is not for you, because the harms of daily aspirin could potentially outweigh the benefits. Now, while just a little baby aspirin is really good to thin out those platelets and prevent blockages in the heart or the neck or the brain, we already did allude to the fact that if you're taking aspirin, one of the ways you might know that it's working is that you start to get bruises on your arms or on your legs, or if you bump into something, or if you nick yourself shaving, you may develop a little bit of extra bleeding for a minute or two. So those are kind of the nuisance events that happen. But for some people, more serious bleeding might happen. For in some predisposed individuals, even a little baby aspirin can be hard on the stomach and cause a breakdown or an ulcer that may actually bleed. And sometimes that bleeding can get quite serious. So, for a person who is otherwise healthy, we don't want them to have bleeding like that. An even more serious version of bleeding might be uh, causing some bleeding up into the brain. It happens rarely with aspirin, but it's certainly there. So the notion is, if you are young and healthy and have never had a heart attack, never had a stroke, never had evidence of blockage, then aspirin doesn't offer you a lot of benefit, but it may have some of these downsides to it, like bruising and bleeding and something more serious. Therefore, no longer recommended for primary prevention. I hope that's clear, and I hope that it's separate. For most people who might be listening to us today, if you've had a heart attack or stroke, stay on the aspirin. But for others, don't take the aspirin. And the encouraging part about this guideline about aspirin that I really like is that they have said you should, if you're really interested about prevention, you've never had a heart attack, never had a stroke, never had a blockage, but you really want to take prevention seriously, then think about healthy lifestyle choices. Think about exercise. Think about eating well. Think about not smoking. Think about managing vascular risk factors. So if you've got high blood pressure or diabetes or high cholesterol, manage that in the most kind of wholesome way that you can with those lifestyle interventions. And if you need them, use the medications to help you out as well. But aspirin might not be in your toolbox right away. Okay, I hope that's clear. A couple of other thoughts about aspirin. So now, hopefully it's clear to you, but if you're still wondering what goes through your mind and what goes through our mind, the decision to start or stop or continue aspirin therapy is individualized. So each person is special, and we need to weigh the risks and the benefits and what's important to you. So there still may be, middle-aged individuals, never had a heart attack, never had a stroke, never had blockage in their blood vessels, but they say, you know what, I really never want to have a stroke. And I'll do everything that I can. And I'm not really so worried about bleeding. So I may choose to take an aspirin. And that's a decision that you're taking for yourself, balancing out those risks. And if the main thing that's in your mind is I really don't want to have a stroke in the future and aspirin might help me a little bit, then I can understand why you might come to that decision. The group also pointed out, after exhaustively reviewing the medical literature, they said they're not really sure about a few areas. Like if you are a young person, say under the age of 40, but you've got some high risk, like you've got high blood pressure and diabetes and high cholesterol, and maybe a family history of cardiovascular disease, is aspirin the right thing for you at that young age? And the issue is we're not 100% sure, and maybe we're actually at a tipping balance point where the preceding decision comes in or discussion comes in. What's important to you? What is your risk of bleeding? And what else is going on in your life? What if you've got something called subclinical vascular disease or asymptomatic atherosclerosis? So somebody might have had an X-ray picture or a CT scan or an ultrasound done of some part of their body, and the report might have come back and saying, there's a little bit of buildup of plaque in one of your blood vessels, but you've never had a heart attack, never had a stroke, never had a full-on blockage in one of your legs. So is aspirin a good idea in that situation? And I think what you will find is your doctors may be kind of two minds of this. And some may say, yes, definitely, let's take the aspirin along with other important interventions to see if we can reduce your risk of bad things happening down the road. But others would say, I'm really concerned about bleeding in your situation, so let's not jump into that. Finally, there are some people who have been taking aspirin for a long period of time. And if I think of my own community in the health professions, it's actually interesting. Back in the days when I was an intern and resident, there was one study that came out called the Physician's Health Study. And one of the things that they studied was whether taking an aspirin was beneficial for somebody in their middle years to prevent heart attack and stroke. And what was very interesting about that was there certainly was a small signal that said the risk of heart attack, you could bring that down a little bit, but it was basically offset by the risk of stroke going up, just as we've talked about because of bleeding into the brain. Now, some of the medical community interpreted that as saying, well, you know what? I think my risk of heart attack is actually greater than my risk of stroke. Therefore, I'm going to be taking an aspirin. And that could mean that there are some people that are taking aspirin for 20 or 30 years. And previously, I think some people, maybe even on this call, might have had a recommendation from their physician or other healthcare professional that said, as part of our general health plan, taking a little baby aspirin is not a bad idea. So we don't know if you've been taking aspirin for a long time, if it's better to come off the aspirin or stay on the aspirin. Because maybe if you've been taking it for many years, the aspirin has actually been helpful to you and helped you avoid having a heart attack or stroke. And maybe if you've been taking it for many years and you haven't had a serious bleeding event, maybe you're a non-bleeder. And therefore, in your situation, it actually makes sense. So these important questions remain and highlight the importance of you jumping into that conversation, leaning in and asking your doc about whether aspirin is the right thing for you. But let me emphasize once again, if you had the heart attack, if you had a stroke, if you had a serious blockage, aspirin is the right medication for you. Some of you may be taking something beyond aspirin, aspirin plus another blood thinning medication, or some of you that are on stronger blood thinning medicines like warfarin or Eliquis or Pradaxa or Xarelto may not be taking aspirin because you're taking one of those stronger blood thinning medications. Okay, let me move on to part 2 of the discussion, and then we'll jump into your questions, if I may. Part 2 of our discussion deals with these interesting blood pressure medications. And you may recall, gosh, has it been 2 months already ago? 2 months ago, we jumped into a conversation near the beginning of the pandemic about concerns about blood pressure medications in the setting of COVID. And this headline from Newsweek, some of you may have even been on the call at that time, we jumped into this study that said there is a controversial study that was published that links COVID-19 severity to ACEs and ARBs. We'll describe those in a second, but those are 2 examples of common blood pressure and heart medications. So controversial study links COVID-19 to these medications, despite warning of no sound scientific basis or evidence. And this set off a whole firestorm of editorials, commentaries, opinion pieces, lots of headlines, lots of concern from medical community and patients about the safety of these medications. Because I think all of us at the beginning of COVID were really worried that COVID would be a tragic event for all of our patients. And indeed, it has been for many, many people, but we wondered about the role of certain medications in that mix. And I'll remind you that there were 2 publications that pointed to a potential concern, very theoretical, about blood pressure medications. And this one in the Journal of Travel Medicine that was published on March the 23rd said, gosh, in a very experimental model, looking at the circulation in the heart and the lungs with animals, it said that if you use certain medications like the ACE inhibitors and angiotensin receptor blockers, that you might increase the number of these receptors. If I make a little wise with these things, these are meant to be receptors called ACE2 receptors. And they're important because these receptors are where theoretically the COVID-19 or SARS-CoV-2 virus would come in and attack. So more receptors, theoretically more attack. And then somebody wrote, or a group of investigators wrote this editorial in The Lancet. So very important, prestigious journal, asking the question, are patients with hypertension, therefore, and diabetes at increased risk for COVID-19 infection because of this idea of the receptors, the medications, and the virus interaction? So if we go back one step, I'll remind you, and we discussed this in medications and other times, that we have this circulating substance called angiotensin in our body. It's a hormone that works on blood vessels, and angio referring to blood vessel and tense referring to tense, meaning we got stuff that will make blood vessels squeeze down like this. Here's the dynamic version of the fists on the screen. And if those things happen like that, then that makes blood pressure go up. And that's not such a nice thing for your heart, or if you're living with a stroke or other blood vessel problems. You would rather your blood vessels be nice and relaxed, your blood pressure to be lower, for you to be calm. And the way that then we might do that is by using medications that might interfere with angiotensin. And ACEs, you might have heard this term, angiotensin converting enzyme, ACE inhibitor. These medications block the formation of angiotensin. ACE inhibitors you recognize as these medicines that end in pril. And here are a few examples of those prils. Ramipril, lisinopril, perindopril might be the most common ones that we use today. And maybe half of the folks that might be on this call are taking one of these pril medications, either to lower your blood pressure, relax your blood vessels, and they certainly smooth things out if you've had a heart attack or living with heart failure. Sometimes, though, that the ACE inhibitors may not be well tolerated because of a cough or something else. So there are these related medications called angiotensin receptor blockers. So instead of blocking the formation of angiotensin, they block the receptor and therefore block the action of angiotensin. And the net effect is the same thing, that blood vessels relax. And these medications all end in sartan. Here are 6 examples of sartan, and drugs like valsartan, telmisartan, irbesartan, candesartan are common examples of these. But both of them you could appreciate work on the angiotensin receptor system, relax blood vessels, lower blood pressure, smooth out the blood flow for everything. So they're a very good idea. And in fact, in people who've had a heart attack or living with high blood pressure or heart failure, the use of these medications has been shown to reduce the risk of bad vascular things happening, like heart attacks, like heart failure, like stroke. So they clearly have an important role. Now, as we've kind of pointed out, that in the COVID-19 story, we've got these virus particles that are being transmitted around in droplets. They might get to us through the airways and down into the lungs. It can also attack us through the gastrointestinal system. And in both of these places, we have these things called ACE2 receptors that will attach with the virus. So the ACE2 receptors, again, become part of this story. And the issue is that the ACE inhibitors or ARBs may increase ACE2 and therefore may cause infection risk to go up. And that's what those couple of studies from early March were trying to allude to, without actually a whole lot of evidence from people. And the first couple of reports that we talked about back in March said that, this might be important because we knew from reports from China and Italy, where there were the first kind of the big waves of COVID-19 before North America and elsewhere in the world, about 15 to 30% of people who ended up in hospital with COVID-19 had high blood pressure. So it made them wonder, maybe these medications will be important. I'll point out, though, that 15 to 30% of anybody that's hospitalized, of any group of people that are hospitalized, will have had hypertension. So it's not unique to COVID. It's about anybody that ends up in hospital. And in fact, most people in the community, in the world, who have high blood pressure were not infected. They were not hospitalized. So while in theory there might be something going on here, maybe it's just a marker of people who land in hospital in any ways. And then the second idea was that same, China, Italy, 15-30% of people hospitalized with COVID-19 had hypertension, that some proportion of them would have had ACE or ARB medications in their treatments. And therefore, when the authors were making their speculative statements, they said, therefore, ACE or ARB must be bad for these people. So we got to think, again, very common medicines in the population, very common to have hypertension. We're going to expect a lot of people are going to have ACE and ARB. And whether you get infection or not, you may be on an ACE or an ARB. And that was our kind of rebuttal to this. And, on the other side, there were actually some interesting studies that were suggesting that you might actually reduce the risk of infection or reduce the severity of infection with COVID-19 by use of these medications. So gosh, it was really mixed up in terms of where the truth of this was. So I thought it was worthwhile 2 months later, as the story is unfolded further, to revisit whether there is something to this story. The kind of the call to be calm and rational at the end of March, I think, has borne out. The kind of the opinion leaders said, this is a huge controversial issue, but there are no clinical data that support the hypothesis that individuals taking these medications are more likely to be infected with COVID-19. That the first articles that suggested this were based upon limited animal data or a whole bunch of speculation. And we don't need sensational journalism. We need stability. And most societies, in fact, called for this at the time. And whenever I had a conversation with anybody, I said, these medications are really helping you in a big way. They prevent heart attack. They prevent stroke. They prevent other bad things from happening. Don't stop them all of a sudden. So I found this update as I was getting ready for this session today, and this from the World Health Organization site, which I do believe serves an important role in the world in managing all kinds of medical conditions, including COVID. COVID-19 and the use of angiotensin-converting enzyme inhibitors and receptor blockers, the team at the WHO undertook a review of the literature that's come up in the last 2 months. And they said that there were 11 new studies that were reported, 8 of which were conducted in China, 1 from Italy, 1 from the United Kingdom, and 1 from the United States. And they looked at that question, does COVID-19 and being on an ACE or an ARB increase the risk of infection or increase the risk of severity? And what they found consistently was that being on one of these important medications was indeed not found to be associated with increased severity or increased frequency of COVID-19. And in fact, one of the articles from the United Kingdom looking at 1,200 people who had been hospitalized with COVID-19 suggested that the likelihood of severe disease was in fact 30% lower if you happen to be on one of these medications. Now, it doesn't make us want to run out and say, go take these ones, go take these medicines if you don't have a reason to. But I think it certainly does reassure us to say, if you're taking one of these things for good reason, then please don't start. That's very important. So the advice from our leading cardiovascular organizations, both in Canada and around the world, the team came out with this guidance in late March, and it's still absolutely true. Do not stop taking your blood pressure medications, including your ACEs and your ARBs, unless advised by your physician. And not taking your medications can, in fact, lead to uncontrolled high blood pressure and hospitalization and other vascular events. So that's where we've made sense of the original stories. It cautions us to be really careful about data and headlines and opinions until they are better informed by real information. And I think this theme is common to many of our discussions today. All right, let me turn this to the group at this point and see if anybody has any questions. And I'll turn to the chat box. And one of you asked a few minutes ago, does aspirin cause any problems? And particularly, are there any issues with the liver especially? And we did go through the issues that aspirin may cause, at least the most common ones. That is bruising, bleeding, sometimes serious from the stomach or into the head. Some people are sensitive to aspirin and indeed allergic. There are a few people that have a severe version of asthma. Not everyone with asthma, but a few people with severe versions of asthma, in which case the aspirin may cause a severe allergic type of asthma, asthmatic attack. So aspirin should be avoided completely in that kind of individual. Aspirin in large amounts. So unfortunately, we do see occasionally people trying to overdose with aspirin. And if that happens, that can be very challenging for the entire body, because aspirin is also an acid, acetylsalicylic acid. And having a large amount of aspirin in the system can really stress out the body. And I'd be more concerned about kidney problems as opposed to liver problems. And finally, one individual says, thank you for the reassuring update about ACE inhibitors and COVID-19. This person has been concerned. I do appreciate that comment back, and I hope we feel a little bit more reassured that the medicines that we might be taking overall to help us out with our heart health indeed do have a good role. They are safe in this time and age, and that not taking some of these therapies is probably more harmful than stopping them altogether. Okay, I don't see anything else in the question box, so I'm going to then proceed with just a couple of other closing thoughts here. As mentioned, every Tuesday and Thursday, Rob Birdlick has offered up a walk and talk with Rob. So please join in at 1 o'clock tomorrow. Rob may walk and talk with some guests at appropriate physical distance and or use of personal protective equipment. But I do encourage you to not only get active, but to have some of your important questions addressed on an ongoing basis. And I know these sessions will be really well done and be very informative for you. In addition, tomorrow morning will be our next in the series of live exercise classes with for our Women with Heart online group. And Lauren Jenkinson, who's one of our outstanding cardiac rehab supervisors, will be pleased to bring this session called the ABCs of Exercise, 26 ways to add activity to your day. So please join us for that highly orchestrated session at 10 o'clock tomorrow morning. And that brings us to the end of this session. I thank you very much for joining in with us today. And I wish you all excellent health, and please get out and enjoy some weather at the appropriate distance. Take care.